So now we are taking you to the emergency management of the asthma exacerbation. So in the next 15 minutes, we are going to discuss diagnosis, classification of asthma exacerbation, management, and some recent updates. So, what is the asthma exacerbation? For few patients, it is the first presentation in the emergency. So, they present with symptoms of wheeze, cough, and respiratory distress. But usually, it is described as it is the worsening of symptoms, which is already diagnosed as asthma, and loss of control of the asthma symptoms, which requires ED or healthcare visit. And when the patient is failed to manage at home, and they have asthma plan, which is provided by the some primary physician, and they ended up to you with the acute onset of the symptoms. So the symptoms include cough, wheeze, shortness of breath, and chest congestion, chest tightness. And usually these symptoms are due to the inflammation and narrowing of the airways. So Dr. Asma has already discussed the trigger factors of the asthma exacerbation, but while taking in, history in the ED, you need to keep in mind all these risk factors. The important point I want to highlight that you need to identify asthma related death risk when the patient landed up in the emergency, because these patient requires your more attention, and these patients require frequent monitoring. So these includes if the patient has a history of prior mechanical ventilation history, hospitalization or ER visit in the last 12 months due to the asthma exacerbation, recent oral corticosteroid or frequent use of inhaled corticosteroids, increased use of salbutamol each month, non-compliant patients, lack of asthma action plan because they don't know what to do in the emergency situation, some comorbidities, and low socioeconomic factors. So always when you are receiving a patient with asthma exacerbation, please identify the high-risk patients. So in the emergency, we have the mantra of A, B, C, D, E. We always go about A, B, C, D, E. In the airway, you need to assess the patient, like, is he able to cry? Is he able to speak? Is he able to complete his sentence or not? And the breathing part, you have to assess respiratory rate, oxygen saturation, increased work of breathing, chest air entry or wheezing, and silent chest. For circulation, tachycardia, hypotension, poor perfusion, all these are the danger signs. And the disability part, patient may be, for in the severe asthma, usually patients are anxious, agitated, they are hypoxic. So they need their support. And the exposure part for the E, you need to expose the patient to find any signs of allergies and any signs of anaphylaxis, because this is the one of the most important differential you need to rule out in the emergency setting, because it has a separate management. So how to, once you have diagnosed this is the patient of asthma exacerbation, how will you assess the severity of the asthma exacerbation? There are different tools, different societies use different tools, but the important part is you use the same tool at the initiation of the treatment, between the treatment, during the monitoring, and at the discharge. So we usually use a PRAM score in our society, and in the AKU emergency, we use childhood respiratory score, CRS score. So here I mentioned the PRAM score, and due to this score, you need to classify the patient at the initiation of the treatment in which category the patient is falling. Is it mild asthma exacerbation, moderate, or severe, or is it impending failure? So you need to act accordingly. One more important thing, when you receive a patient with the wheeze, it's not always the asthma exacerbation. You need to have a proper history, and you need to rule out the differentials. Like usually small kids less than 2 years present with wheezing are bronchiolitis. Some are cardiac wheezes. Pneumonia has always, pneumonia can give you clue like a localized finding. So pneumonia can present with asthma exacerbation. Okay. So you also need to rule out the upper airway obstructions like vocal cord dysfunction, hemangioma, and large lymph nodes. Lower airway obstructions include laryngeal tracheobronchomalacia or some vascular rings. So ये क्वेश्चन मुझे आप लोगों से करना था, डू वी नीड एनी इन्वेस्टिगेशन फॉर एस्थमा मैनेजमेंट? हमारा बड़ा कल्चर है कि जी सीबीसी सीआरपी और ब्लड कल्चर भिजवा दो, फिर देखेंगे आराम से. सो देयर इज नो, ऑलवेज आस्क योरसेल्फ, Is this investigation is going to change my management plan? No. Do you need CBC? No. Do you need blood culture? No. Do you need chest X-ray? Yes. If you have a differential of pneumonia, you have some localized finding. Like if you have a unilateral wheeze, always go for X-ray first, because unilateral wheeze always trigger the differential of foreign body. So you need to rule it out before starting the treatment. Do you need blood gases? Yes. If you are considering impending failure, you need to go for it. And if you have a normal carbon dioxide level and your blood gas and patient is in the distress, then you need to consider impending failure and you need to get aggressive. Electrolytes? Yes. If your patient is in severe asthma and he's using a lot of salbutamol, so he can have electrolyte imbalance. Also, with this asthma exacerbation, patient is having a lot of insensible losses. So for the insensible losses, you need to get in severe cases. Okay, what should be the objectives of your ER management? Once you have diagnosed the patient, immediately rule out the differentials, then prompt interventions. What should be the interventions? Decrease the respiratory rate, improve oxygenation, and reduce the recurrence. Correction of dehydration, as I mentioned, there is a lot of insensible losses and appropriate disposition and proper follow-up. आपने ICU भेजना है या आपने discharge करना है मरीज को, you should have a plan. Initiate with the we were going to discuss medical management first. What's in the medical management? Treatment of hypoxia, administration of bronchodilators, administration of corticosteroid, assessment of response, consideration of other treatments, and prompt actions. Right? I always say that asthma is a time-bound emergency like status epilepticus. Status epilepticus, you have to be monitored in minutes, but in asthma, you have to monitor in hours. So first line treatment means first hour, right? We have a culture, nebulization लगा दो, assess कर लेंगे. No, you have to be aggressive while managing asthma. Start oxygenation. Why oxygenation? In severe asthma, your patient must be hypoxic. For mild and moderate asthma, in some primary setups, you can go for a meter dose inhaler, and GINA guidelines usually recommend because it's generalized. If you don't have nebulizations with the oxygen and all these things, you can start with mild and moderate. But in severe asthma, with the oxygen, always start with oxygen. Why? Because salbutamol causes VQ mismatch. It causes the blood flow, increased blood flow to the areas where which are not properly aerated, right? So start with the oxygenation, start with bronchodilator immediately, start with salbutamol, and add ipratropium. I would like to emphasize this part. Please do not recommend only ipratropium. It will do nothing, right? It causes a synergistic effect. And steroid. There is another debate which are going to address in next slides. You can have prednisolone, methylprednisolone, and dexamethasone. So which one to choose, right? Now, for the second line therapy, there is equivocal data. Some says it's beneficial, and this part is needs a lot of research, right? But if your patient is not improving, you can start continuous salbutamol inhalation, which is like 0.5 mg per kg per hour, right? Magnesium sulfate, what it helps, magnesium sulfate आपको 30 मिनट्स के अंदर मसल स्पाज्म को रिलीव करता है आपके, राइट? सो फर्स्ट आवर पे आपने पेशेंट को असेस किया, रिकैटेगराइज करा प्रेम स्कोर से, देन यू जंप अप टू द सेकंड लाइन थेरेपीज. सेकंड लाइन थेरेपी में आपने स्टार्ट कर दिए हैं, उसके बाद भी अगर आपके मैग्नीशियम सल्फेट एंड कंटिन्यूस सैल्बुटामॉल के बाद योर पेशेंट इज नॉट इम्प्रूविंग, गेट अग्रेसिव. Start PICU consultation, reconsider your diagnosis, and systemic beta 2 agonist. So there are two choices of systemic beta 2 agonist: epinephrine and terbutaline. So which one to choose? Again, the same question. So if you have ICU backup, you have very good monitoring, terbutaline is the choice because it is selective beta 2 agonist. But if you don't have, like an RED, if I'm not confident, I give IM epinephrine, and I have found very good results. So the most common debate, which one to choose? Why methylpred? Why dexamethasone? I prefer dexamethasone because I am an ED physician and मुझे quick results चाहिए होते हैं. So dexamethasone आपकी मिथाइल पे 1 आवर में काम करेगी, डेक्सामेथाजोन 10 to 30 minutes में. Relative anti-inflammatory activity, dexamethasone has 30%. Relative mineralocorticoid activity, it has 0% mineralocorticoid activity. So I prefer dexamethasone. And one more important thing, it has reduced the issues of compliance. Right? What is the role of aminophylline in the asthma? This is another common debate, and this is an area of research, but it has a controversial role. Narrow therapeutic index. In the therapeutic dose, it usually causes nausea and vomiting, but it can cause arrhythmias, and there are deaths reported from it. So, if you have very good monitoring, you are very vigilant, you can start. So, non standard therapies. Yes, you can attack asthma back, but you can use Heliox. The data is suggesting that simple oxygen is lesser beneficial than Heliox, it's more diffusible. You can use ketamine, right? Low dose of ketamine can cause significant bronchodilation. And if you are going to intubate the patient, then ketamine is the choice for induction. Leukotriene receptor antagonist, it is recommended in some literature that you can use leukotriene receptor antagonist in the acute exacerbation. So, what is the respiratory management? You started with the oxygen inhalation with the nebulization. Your patient is not improving. High flow nasal cannula. High flow nasal cannula or BiPAP. But in the pediatrics, high flow nasal cannula is more tolerable. Invasive ventilation, it is a nightmare for ED physician and it is same nightmare for the PIC physician. आप उसको एक खतरनाक तोहफा दे रहे हैं जिसपे वो आपको अच्छे से दुआएं देगा फिर जिंदगी भर. Why? Because you have put a foreign body in the trachea and continuous stimulation दे रहे हैं आप उसको. So high flow nasal cannula क्यों इतना अच्छा है? It is the favorite thing which मतलब मुझे लगता है कि it's a lifesaver for the emergency physician. It improves the oxygenation, decreases the work of breathing, expands the lower airway, reduces the dead space, and should be used in the PICU setting. ये सिर्फ याद रखने के लिए है, जैसे डीके के अंदर होता है ना, अगर आपका मरीज इंट्यूबेट हो गया, आपने सही से नहीं देखा है, इसी तरह अगर आपका मरीज एस्थमा का इंट्यूबेट हो रहा है तो इसका मतलब है यू आर इन ट्रबल. So clinically, अगर your patient have altered mental status, progressive exhaustion, silent chest, cardiac arrest, respiratory arrest. Laboratory में severe hypoxia, because आपने बीजी तो तभी करानी है जब आपका patient severe impending failure में लग रहा है. pH less than 7.2 and PCO2 rises by 5 millimeter Hg per hour. ये चार्ट है जो कि बहुत लाइफ सेवर चार्ट है. आपने क्लासीफाई किया, आपने देख लिया क्या क्या ट्रीटमेंट करना है, फिर अगेन क्लासीफाई किया और दोबारा असेसमेंट कर लिया, तो ये आपको हाथ पकड़ के चलाता रहेगा. सो यू नीड टू गो हियर एंड देयर फॉर फाइंडिंग थिंग्स, राइट? These were my references.